Good afternoon, everyone. It gives me immense pleasure to be here and talking to on current status of PCD diagnosis as well as management. And the next 20 minutes, we'll see what is PCD and then when to suspect PCD in a clinical situation, and we'll talk about in detail diagnostic tests and a little bit about management of PCD, and finally we'll summarize. And we all know that cilia is a microscopic hair-like structure that is present in almost all mammalian cells. Cilia are basically classified as sensory cilia or primary cilia, and which is immotile, which is present in all cells. And in PCD, we are talking only about motile cilia. And PCD, we all know, is a genetic condition affecting both the structure and function of cilia, and which results in impaired mucociliary clearance. That's why we get recurrent chest infections as well as bronchiectasis. And it's also associated with risk of organ laterality defects, that's situs inversus or situs ambiguous. And some patients land up as adults with infertility problems. And overall, if you take worldwide prevalence of PCD is about 1 in 7,500. But we don't have data. There is paucity of data on Indian population. But there are some studies done in Western population, especially in UK. And it shows it's not Indian population, it's more of Asian population. It shows that PCD is more prevalent in in Asian population compared to Western population. This is in contrast to cystic fibrosis. Therefore, we can expect, if you do a study, we can expect more PCD patients in our population. And the key here is making early diagnosis. And in 1933, Cartagena, he's an adult physician. We have to note that. And he identified 3 components, the triad: bronchiectasis, sinusitis, and situs inversus. And later it was clubbed and put together as Cartagena syndrome. But we don't want to diagnose Cartagena syndrome and pass it on to the adults. We actually want to diagnose PCD early, when it is early, and prevent patient developing or delay progression of lung disease and development of bronchiectasis. Therefore, how to do it actually? And North American, there is a North American criteria. It tells about 4, cardinal features. That's one is neonatal respiratory distress. Second is laterality defects, organ laterality defects. Both of these features can be identified in the neonatal period. Therefore, we have to make aware neonatologists about these 2 things. And neonatal respiratory distress, when you go into the details of neonatal respiratory distress, you have to think about 3 L's. It's usually late onset, after 6 hours, the respiratory distress. And second thing is, there might be associated lobar collapse. And in this respiratory distress is not like TTN, it might be long lasting. Therefore, if you encounter such kind of respiratory distress in a term cell, you have to think about PCD. And apart from these 2 features, and these children usually have year-round upper respiratory and lower respiratory symptoms. And if you have at least 2 of these 4, you have to suspect PCD. And this is quite simple for office use. And we also have the Picarda score, which we have been discussing for a long time. And the Picarda score, we score children who have persistent or year-round wet cough. And this score has 7 components in it. And out of the 7 components, we can get a total score of 14. And a score of 5 or above have a high sensitivity and specificity, combined sensitivity and specificity for detecting PCD. But if you closely look at the Picarda score, if you look at the first 5 components, everything can be identifiable from the neonatal period. Therefore, neonatal history is very, very important for identifying PCD. And apart from that, therefore, when you have clinical symptoms, better to use a clinical tool, either North American clinical criteria for PCD or the Picarda score. I feel the North American criteria is slightly easier. And once you suspect PCD, you have to go for diagnostic testing. And if you don't have diagnostic testing, straight away start treatment. Treatment is only basic. Airway clearance therapy is the cornerstone of treatment. It doesn't cost much, but it's very effective compared to cystic fibrosis. Therefore, you straight away start treatment. Don't wait for your investigations. But if at all you have investigations, go for it. And we usually use a combination of tests. There is no gold standard test. The upfront screening test will be your nasal nitric oxide and high-speed video microscopy. And then if you want to confirm, you need either genetic testing or like your electron microscopy. And I'll touch upon each of these tests. Nasal nitric oxide first, it was first described by Lundberg et al. They found that in PCD patients, the nasal nitric oxide was abnormally low. And there are equipments to measure nasal nitric oxide. There are two kinds of equipments. One is a portable equipment which uses the electrochemical method, and there is a stationary equipment which is which uses chemiluminescence technology. The chemiluminescence technology is expensive but more accurate. But this portable one is easily available, and it's easily available in India as well. It's called, we have a machine called Neox Viro. And the good thing about, doing a nasal nitric oxide test is you don't need much of expertise. You just need the equipment. Ordinary lab technician can do the test. And the main limitation is, it's standardized only for children more than 5 years. Therefore, with that, we can screen only children above 5 years of age. And second limitation is, it can be normal with some genotypes, and it can be low as well in other conditions like cystic fibrosis, or if the patient has chronic sinusitis causing obstruction of the ostia, then you can have a low values. Therefore, even though it's a good test, you have false positives and false negatives. You need to know about that as well. And what we do along with the nasal nitric oxide is high-speed video microscopy. Basically, this is a simple test, but you need a little bit of expertise. You take nasal brushing with a cytology brush or a bronchoscopy brush at the level of inferior turbinate from nasal mucosa, and then transfer it to a transport medium. We call it 199, and then actually look under a light microscope. Therefore, this is not very expensive. Only thing is you need to attach a camera, and we use a high-speed video camera which comes with the software. It is not very expensive. It costs around 3 lakhs rupees for us. And then what we do is we actually make a recording of the ciliary movement and then run it in slow motion with the help of the software. And we look for two things mainly: the ciliary beat pattern and the ciliary frequency. And I will share some of the videos. And first one is a normal video where you can see in a healthy cluster, healthy cell cluster. Before we study the ciliary motility, we make sure the cells are in cluster. We don't study individual cells. We study cells which are in clusters and make sure the clusters has to be healthy. If it is unhealthy, you might be looking at secondary dyskinesia and might be reporting as abnormal. Therefore, you have to make sure your clusters are healthy and then go for the interpretation. And the movement will be like a to and fro motion, like the car wiper. Next one, I am actually running the video. You see a healthy cluster, and you can see ciliated cells, well ciliated, and you can it's static. Cilia are almost static. You can just see a flicker of movement. This is almost immotile cilia. And the third video, you have movement. It's not a to and fro movement. It's a very stiff movement. This is dyskinesia, primary ciliary dyskinesia. Okay, this is a dyskinetic movement, very stiff movement, and this is more of wafting movement like a seaweed. This is not the to and fro motion you looked at in the normal video. And finally, this is a rotational motion, and you get this kind of motion in central tubular defects. Therefore, whenever we do a high-speed video microscopy and do the interpretation, we first make sure we get a good quality, video, and to ensure that you have to see clusters, and that clusters has to be healthy. Then you classify, whether it's normal or abnormal. If the cell clusters are not healthy, you don't actually interpret. You make it, you actually classify as inconclusive or indeterminate and repeat later on. And coming to genetics, in 1999, actually the first gene was described by Penuren et al. And so far, like 50 genes, mutations of 50 genes have been found to be causative of PCD, but it accounts for only 75% of our PCD patients. Just 25% we don't know the genes. There are about 200 ciliary proteins, but we have identified only 50 genes. Therefore, whenever you do genetics, you should know the limitations. Genetics won't pick up all your patients. Therefore, positive genetics will help. If it is negative, it won't help. You have to look at other tests. And you also have problems with VUS. And transmission electron microscopy, again, it requires equipment, expertise, and it's expensive as well. Turnaround time is also almost takes about a month. And if you get hallmark defects, it's helpful. Again, 20% of PCD patients can have a normal ultrastructure. Therefore, you might not pick all patients with PCD by doing an electron microscopy. And immunofluorescence, is a very promising. You actually use antibodies, immunofluorescent antibodies against ciliary proteins. And there are antibodies against important ciliary proteins, and you can actually identify ciliary defects by immunofluorescence. And it's going to be an alternative to electron microscopy, especially in resource-limited settings. And there are lots of places immunofluorescence microscopy is available, and it won't take much time, and it's not that expensive as electron microscopy. But it's not a very sensitive test, it's an add-on test. And coming to a common test, what we do apart from your diagnostic test is a CT scan. And here, unlike cystic fibrosis bronchiectasis, here is more of middle lobe and lower lobe. In cystic fibrosis, you get more of upper lobe involvement in case if you get bronchiectasis. But if you do early on, you might get lobar collapse, or you can get mucus plugging. And apart from your CT scan, there will be upper airway involvement. We already talked about it. And if you do X-ray PNS, you might see reduced pneumatization of your paranasal sinuses. Regarding microbiology, and Dr. Gary has already mentioned, what we get as common organisms is H. influenza, Moraxella catarrhalis, and pneumococcal. And once the disease progresses, the patient might acquire Pseudomonas as well. And what helped us to set up a unit is basically a collaboration between us and Southampton team. And we learned all the diagnostic tests from them and started our diagnostic unit in 2017. And this is what we have done so far. We have worked on patients with suspected PCD. We had about 113 patients, and then we actually screened with both high-speed video microscopy. But whenever feasible, we also did nasal nitric oxide. I already told the limitation of nasal nitric oxide is you can't do it less than 5 years of age. Therefore, we did HSVA for all patients and did NNO whenever is feasible. And we identified 68 patients who are PCD highly likely and started treatment straight away. We don't wait for confirmation. And then patients who could afford, we did our genetic testing, NGS. That was it was 26 patients. Out of that, we got biallelic mutations in about 19 patients. That accounted for about 75%. But the mutations were actually pathogenic in only 50% of patients. Therefore, a word of caution. Okay. Therefore, if you do genetic test straight away, you won't be covering 100%. You might be covering only 50%. Therefore, rest 50% don't discard. They might be PCD as well. And this is something we learned that doing both has its advantage. Both screening tests, nasal nitric oxide and HSVA, because in HSVA, as I said, it's not normal and abnormal. It's normal, abnormal, and indeterminate. And in these indeterminate patients was quite a number actually. It's around 25%. And those patients, nasal nitric oxide helped. And in children less than 5 years, HSVA helped. Therefore, it's better to do a combination of tests whenever feasible. You will be picking up more patients who are PCD highly likely than doing one test. And these are the clinical characteristics. We all know that worldwide, the median age, especially in West, the median age of diagnosis is around 5 years. We are diagnosing at 12 years. And most of them, around 70% of them had bronchiectasis at the time of diagnosis. And you should not rely on your situs inversus to make a diagnosis of PCD, because in our cohort we had only 20% of patients who had situs inversus. The rest 80% didn't have situs inversus. Therefore, you should not cling on to situs inversus to make a diagnosis of PCD. And this is a small case capsule, how we go about an individual case. This is a 4-year-old child who presented with year-round cough and recurrent chest infection. Then we applied the North American criteria. This patient had 3 criteria positive, which is shown in red: neonatal respiratory distress, persistent wet cough, and persistent nasal discharge. Normal situs. This patient had normal situs. And Based on the criteria, there were 3 cardinal features, and Picarda score was also high. We did HSVA, and this was the finding. Can't see any cilia, okay, and repeatedly we didn't see any cilia, and it's absent cilia, and this is CCNO mutation. CCNO mutation, there won't be ciliogenesis, therefore it will be absent cilia. And management, already Gary has touched upon it, touched upon. What I would like to say is CF is a more expensive disease for us, but PCD, if you diagnose early, you can make a difference because it's not very expensive. And we might think, airway clearance is a very simple measure, but it's also an effective measure. Apart from that, we have to regularly monitor their microbiology, as well as we have to monitor their lung function, and you have to treat infection once you identify. And we should also concentrate on the nutrition, immunization, and we should avoid from their environmental hazards. ENT, we do a nasal wash on a regular basis. We ask them to do a nasal wash, and we have to screen for hearing. These patients can have conductive hearing loss. And being a genetic disease, it's a disease of the family, not only of the child. You have to counsel the family and screen the family as well. We had 3 patients who had siblings had PCD. Therefore, we have to screen the family. Challenges in India is underdiagnosed and underdiagnosed disease, even in Western population. There's one study tells that 70% of the patients have seen a doctor 50 times before a diagnosis is made. Therefore, symptoms are very non-specific. They can masquerade, like a normal child or a child with atopic disease. You have to look closely to make a diagnosis. And second thing is the awareness is now better, but is still very poor about PCD. And we don't have diagnostic tests, but now tests are coming up. We have seen lots of papers on, like high-speed microscopy in this particular conference. It's very encouraging. Therefore, we might, I just did a calculation, we might be having 20,000 patients, children with PCD, and most of them undiagnosed. And the summary is early diagnosis is key, and it's not a very expensive disease to treat. And it's important to create awareness about PCD. And once you have awareness, then you suspect. Once you suspect, then you use the clinical tools. You have 2 clinical tools, North American clinical criteria and the Picarda score. Use that tools to make a clinical diagnosis. And once you make a clinical diagnosis, you can refer to a center which has PCD diagnostic facility. I think we need to have more PCD diagnostic units, and all those who are doing CF work are ideal places to have PCD diagnosis as well. And we learned by collaboration, and we are happy to collaborate with other centers who want to learn from our experience. Thank you.
Okay. A small introduction, brief introduction.
Just a minute, I have not finished yet. I would like to acknowledge Professor Jane Lucas and team from Southampton, and they actually trained us, and my pathologist who is doing HSVA, Dr. Ram Ganesh. Thank you. Sorry.
A brief introduction of, hold on, stay here. Dr. Antony Terrance Benjamin, he is from Coimbatore, and as you have all seen what beautiful presentation he made, he has a special clinic of this PCV and sleep medicine. Sleep medicine is a recent, very important aspect of pediatric domain, and thanks will be offered by my co-chairperson.
Thank you for this wonderful talk, and you enlightened us how to pick up the cases. But if we picking up the cases, then the PCD diagnostic facility is not available. So, from clinical point of view, we will pick up. Then what to do next? That is my question.
I think for PCD, it's important to diagnose. That's what is. We don't have any fancy treatment, but diagnosis is a great step for that particular patient.
Clinically, we can suspect.
Yeah, but you can with this clinical criteria, clinical tool, right, you can say PCD highly likely until you have a diagnostic test. Start treatment, which is something basic and very effective. Therefore, right, it might look very simple, whatever we are telling, because if you don't make a diagnosis, you might be giving some harmful treatment which might not be totally necessary for this particular patient. And if you clear the mucus, the patient is going to live longer, lung is going to be more healthy.
So if you can diagnose clinically, then we have to go through the general guidelines. Yeah. Okay, thank you so much.
Hi, I'm Dr. Nitin. I am in AIMS New Delhi. So one thing I want to share is that we can use our mobile phone camera especially in the slow-mo mode,
Yeah.
which gives around 240 frames per second.
Okay.
And in some of the mobiles, it may be going up to 480 frames per second. So with that, you can actually make a recording, and then you can see both ciliary beat frequency and the pattern both. And we are using it for past 1 year, and we have like very good videos.
Yeah.
Second is the microscope that you showed. It's actually a simple microscope.
Simple microscope.
And mostly what is described is a inverted microscope with a well slide.
yeah.
That's what we also use, because the size of cells that you are seeing, you probably using 60x or around 40 or 60x, and that gives very small gap between cells and this. Whether you are able to use it with the simple microscope.
Yeah,
or
we are
you
using
use
it. I've been to a couple of centers who use inverted microscope and light microscope. I wanted one which is very cost effective. Therefore, the microscope is ordinary light microscope. The camera is not very expensive, but the quality of images you get actually is adored by European centers as well. And thing is, here regarding high-speed microscopy, video microscopy, everyone can do a microscopy, but it's important is quality control. You have to make sure you get a good quality video, and we record 8 videos for each patient, and one has to include the top view and the rest side views. If you don't have a top view, you are going to miss rotational defect. And other thing is, it's not about normal or abnormal. You should be able to identify secondary dyskinesia. For that, you have to make sure cell clusters are healthy or not. And therefore, we have lots of enthusiasm about high-speed video microscopy. We have to make sure we give a correct diagnosis.
So which magnification do you use with this simple
We
camera?
use oil immersion, 100x.
So because usually it's a liquid,
Yeah,
right? It's
yeah.
a
We
droplets of-
make a slide. We make a well out of the slide and
Okay,
do the. If anybody is interested, we are.
Just like, do you like hanging drop? Just
We
like
use
hanging-
2 cover slips to make a well in the slide, and it's a very cost effective. We charge only 1,500 rupees, and it's 1/3 of the cost of a nasal nitric oxide, and it's more like doing a urine test for us. Yeah.
Sir, cutoff for nasal nitric oxide, low nasal NO.
Yeah, cutoff, depends on which machine you are using as well as the technique which you are using. If it is expiration against resistance, it's going to be a perfect technique. If you are using tidal breathing, some patients only do tidal breathing. Therefore, cutoff varies, but generally we say anything less than 200 parts per billion is low.
Thank you, sir. Thank you, Dr. Antony, for a nice lecture. Thank you, ma'am.